Hi, I'm Dr. Joe Rogers, President and CEO of the Texas Heart Institute, and I'm joined here in the studio this afternoon with Dr. Shreela Sharma. Dr. Sharma is a professor of epidemiology in the School of Public Health at the University of Texas and the director of the Center for Health Equity. Shreela, your grand rounds today was just so perfectly targeted to help us begin thinking about the challenges of nutrition, not just in the United States, but really globally, and how we begin to think about it in a systematic way and begin to devise solutions. So I just wanted to thank you for joining us after Grand Rounds for a few minutes, just to sort of expand on some of the things we talked about.
Sure. Well, thank you for the opportunity. And yeah, I'm happy to dig in deeper.
So a lot of the people that watch this segment will finish watching and start practicing, back in their offices this afternoon or on Monday. Mm-hmm. And I was really struck by this idea that we all have an opportunity to screen our patients in a different way to understand their nutritional status and their food insecurity.
Okay.
In a practical manner, for people who aren't necessarily affiliated with a large medical center or a medical school and have tools built into their electronic health records, how does the average practitioner go about that in a time-efficient but thoughtful way that at least helps us identify the right patients?
Great question. The good news is that for a lot of these measurements related to food, and so they're short and sweet. There's two questions. So even, a practitioner who may not have a lot of, support in regards to their EMR systems or whatnot can still incorporate that. In fact, a lot of these screeners are sometimes even done on like an iPad or something simple like that. I think the part that is important is to understand what the ecosystem, the food environment of your patient is, right? Especially if you're working with patients from underserved communities or living in environments that are not conducive to healthy eating. Honestly, it's just about having a conversation with them, asking them about their food and what does that look like, and do they have enough access to food? I think a big part of the food insecurity and nutrition security, the two pieces that we like to look at, is honestly about caring for your patient from a social standpoint. And so it's about bringing that social care into the healthcare. So it may not be in the form of a screening. The screener helps standardize, right? Mm-hmm. But as a provider, you can still have that conversation to ask them about what does their food environment look like, and then thinking about, I think the part of it that's probably most critical is what do you do about it?
Oh, well, that was my next question. I think it's not only seemingly an expansive topic to begin to discuss with a patient,
right?
But I think so few of us are well prepared to deal with the answers that we get.
Yeah.
And what do you do when you find out someone is either food or nutritionally insecure? Because I think for many practices in the United States and certainly worldwide, we don't have that next connection that allows us to say, I've identified a problem and now I'm going to propose a solution to you.
Yeah. And that's actually both an ethical question and a medical question, right? Because you don't want to screen someone for something like food insecurity, which is just not having enough food, and then not do something about it. And so that's the ethical side of it. The good news is that I don't believe there's an expectation for health systems to start having farms within their premises. That's not the solution that's likely sustainable. But it's about building partnerships. There's an incredible level. Just in our region, there's over 50 different kinds of providers, community providers, for-profit organizations that are offering solutions like produce prescription programs, 50 of them, 53 to be precise. And so there's a lot of resources out there. And some of the work that we do is connecting those resources, because it has to be the right approach for your patient, right? Meet them where they're at. And so So that's a lot of the work that we do is connecting the health systems, doing that assessment and connecting them to the resources and the response and the interventions, that they need. But the good news is that there's a lot out there in terms of the solution. So I'll give you an example of the Houston Food Bank, right? The Houston Food Bank has a program called Food for Change. And as part of the program, they offer a produce prescription program. And so any patient can receive a prescription to go to any of their pantries and redeem it. And they get either a home delivery or they can pick it up right there, about 30 pounds of fresh produce, and they can get it consistently for 6 months, and they can then renew the prescription. So there's solutions out there, and it's about the provider sort of saying, I want to do this, and making sure if you're starting the screening to ensure that there's a response attached to it. I think they have to go hand in glove.
So go to the next step in this thought process. So I think you made a very compelling argument that we eat the way we grew up.
Yes.
And so I could easily imagine handing someone 30 pounds of produce and saying, now we've given you food, problem solved. And people go home with those bags of food and think, I have no idea what to do with any of this food that I just received. But so what's that next step then?
Yeah, great question. So there is this very real phenomenon called intimidation by produce. You go to the grocery store. For all of us, we buy what we're familiar with, that we know how to cook, and that we know our kids and our family will eat.
Yep.
That's the bottom line, right? And that's where the intimidation comes at. If I only have $2 in my pocket, am I going to spend it on the Brussels sprouts that I have no idea what to do with, or my kids are not going to like it, right? Mm-hmm. So I'm not going to spend it. I mean, I, as an immigrant, came to this country and circled the broccoli for about 6 months because I'd never seen broccoli before, and I didn't know how to cook it until my roommate said, like, all you have to do is roast it. And I put some olive oil, salt, and pepper. It's going to taste good. And to this day, that's how I eat it and my boys eat it. So someone has to hold your hand in terms of breaking down those barriers to demystify the produce. And I'll tell you a real story real quick. We had one of the programs, Food as Medicine programs that we've developed, and it's scaled now. It's called Brighter Bites. And we were working with this mom, and she said, this is with pediatric populations, and she said, I never bought Brussels sprouts because when I was growing up, my mom used to boil them, and she hated the taste of, well, nobody likes boiled Brussels. But, and through Brighter Bites, we taught them how to just roast it. And her boys loved it so much that even when she doesn't get it through the program, she now feels comfortable spending her money in the grocery store on buying Brighter Bites. And to me, that's not just the behavioral, it's an economic impact too. Sure. Now she's spending that money on buying a healthy product, which she didn't used to before. Yeah. So I think there's a value proposition even from the economic side.
So I want to get your perspective as a clinical trialist with this next question. So today it seems like a lot of this is hand-to-hand combat. When you're teaching someone how to eat differently or cook differently, it's a very sort of personal one-on-one kind of intervention. Mm-hmm. How do you scale it? I mean, how are we going to change the way populations of people consume food, prepare food in ways that are going to make them healthier in the long run?
Yeah, we're going to use the sandwich approach.
Tell me more.
So the sandwich approach is where we're at the bottom, we're going to have to make it the norm, right, where we're creating these partnerships to implement produce prescription types of initiatives. And so that's from the policy. So the top layer is the policy layer. And, as I mentioned in the Grand Rounds, we do now have the policy mandate from CMS, right, in regards to screening for social drivers of health. So health systems are now going to start thinking, incorporating it, but we have to be ready for it equally from a clinical trial, with interventions that are actually effective and efficacious in improving outcomes for the patient populations that they are screening, right? Because otherwise you run the risk of implementing something that doesn't work, right? And so, or the uptake of it's really low. So, in the space of clinical trial, we think about implementation outcomes to drive then efficacy and effectiveness. And so when you think about the implementation outcomes, that's then when you can think about scale, right? Because if you've done your job right in thinking about dosage and thinking about reach and thinking about uptake, adoption, all of those components, then your patients are going to adopt. They're going to pull it in, right? And then that's how you're going to scale it, because the adoption is at its best, so you're going to see the impact. I will say the other part of it that we're paying a lot of attention to is the cost, right? Ultimately, there's that component to it, and ensuring that we are documenting, what it takes to scale these programs. And there is efficiency of scale. There's huge efficiency of scale in these stuff, because it's much easier for community organizations that are doing this work to feed 1,000 than it is to feed 100 to provide this program. So there is efficiency of scale even from the community organizations side of things as well. So, but a big part of it is also bridging the data gaps and making sure that we're building out the model, keeping that sustainability and scalability in mind.
I mean, I'm just so appreciative that you're putting science behind this. I think it's going to create the most compelling argument. I have one more question before we wrap up. I'm very interested in the fact that this is one of the pillars of the social drivers of health, is food insecurity, nutrition insecurity. But you talked about the interrelatedness of the different pillars. It's economic security, it's, sort of early childhood experiences. And I guess the question for us to think about as a medical community is how much of this will be solved by medicine, and how much of this is really going to require that we begin having conversations with very different groups of people, because I don't think medicine's going to be able to address all of those things that are so highly interrelated.
Yeah. No, and you're 100% right. The intent is not for the health system to take all of this on. The intent is for the health system to be part of a larger conversation where we need all different forms of sectors, and starting with as our school systems. If we really want to think of prevention, that's where we need to. So we need, the home environment. We need the parents. We need the provider community. We need school systems. We need multi-sectoral approaches to this work. For the longest time, I mean, this, nutrition education has vanished. It's from our schools. It's not a part of the medical curriculum in any substantial way, or nursing. So it's gone away from our lives. So how can we expect our parents, our providers, our school teachers to talk about these things that never been part of the ecosystem? But what has been part of the ecosystem is fast food restaurants, ultra-processed. There's extensive exposure to that, right? So that then becomes part of your conversation, right? So a big part about this is not about health systems sort of taking this on in its entirety, but being at the table in having these conversations where along with everybody else. Because I think the part that's important to remember is the solutions that are going to be most sustainable ones are the ones that are driven by policy, to be honest with you. And so how do we, but we need everybody at the table to help drive those policy conversations ultimately.
I think you and I probably could go on, and talk about this for another hour, which means that we're going to have to invite you back for grand rounds sometime soon.
I'm here for it.
So thank you so much for spending time with us at the Texas Heart Institute. And thank you again for grand rounds and for spending a little bit of time in the studio. This is Joe Rogers from the Texas Heart Institute, thanking Dr. Sharma for a really terrific day. Thank you very much.
Thank you.